Significant morbidity has been identified in patients with immune thrombocytopenia, or ITP, and the disease can impact quality of life in many ways. Here, one patient shares some of her experience.
My name is Jen Grimes. I am 44 years old. I was diagnosed with ITP in 2008 at the age of 28 after the birth of my second daughter.
Increased bleeding tendency is the central clinical symptom of ITP. Heavy menstrual bleeding is common in female patients with ITP and is one of the most severe symptoms.
Part of the ITP, I was having extremely heavy menstrual cycles, and my cycles were every 23 days. So I wouldn't really get a break, and you have those 23-day cycles where you're heavily bleeding. I couldn't recover. There was nothing that I could do to get my iron counts up. The fatigue related with low iron it's almost indescribable. It's almost like you're walking through in a haze because you're just so exhausted. You're not really sure what's going on some days.
ITP can also affect a patient's psychological and emotional well-being.
It truly is a roller coaster. I have so much anxiety related to this illness, so to speak, this disease, and it affects everyday life. I'm on edge when I go to the doctor. My poor husband is on edge with me because he's on this roller coaster ride with me. It really does kind of affect everything. It provides a level of stress. It's hard to manage sometimes.
Good afternoon, everyone, and welcome to this symposium. It's really a joy to get to speak with you all today about collaboration in chronic ITP, improving quality of life and patient outcomes. So it's my pleasure to be here today with this panel, including Professor Kuter and Dr. Castellano. So for our agenda today, we're really going to focus on the impact of ITP, and we're going to do this in the context of some novel therapies and really ultimately trying to put it together to how do we navigate this new landscape with the patient remaining the focus of what we do every day. Throughout this talk, we're going to explain the natural history of ITP and the chronic phase and the impact on patients. We'll discuss the current and future treatment strategies to improve the quality of life of patients living with chronic ITP. And we'll delve a little into the practice of shared decision-making and collaboration to optimize our outcomes for our patients. So I'm going to begin with talking about the impact of ITP on patients. And this slide is a really general overview of ITP that many of you are already familiar with. We know that ITP is an autoimmune disorder of primary hemostasis. It's considered a rare disease. The prevalence is about 9.5 per 100,000 adults. It does seem to have a higher prevalence in women than men in sort of the younger adults, but the two become equal in older populations. In 60% of adults, this will progress to a chronic disease of greater than 12 months. And I really think that's fundamentally important when we think about this. This is a chronic disease comparable to other chronic diseases that we manage in patients. Patients have a slightly higher overall mortality than the general population. And unfortunately, ITP still remains to this day a diagnosis of exclusion based on having a platelet count less than 100,000 without any other real underlying cause. Central to having ITP is an increased bleeding tendency. About 60 to 70% of patients with chronic ITP have symptomatic bleeding at any time, and this can occur anywhere in the body, obviously with the sites that we're most concerned about being either intracranial hemorrhage or intra-abdominal. And even skin manifestations, while maybe seemingly not that important to us as the physicians in terms of being alarming, can be quite alarming and distressing to patients. We're also starting to appreciate the non-bleeding symptoms of ITP. These are things like fatigue, cognitive impairment, and we'll get a little bit more into these, and I'll share some data with you just to really help us reflect on the full picture of living with ITP. The other thing that we know is we use our platelet count as a surrogate, right? That's our clinical endpoint in clinical trials. That's a thing that makes us feel good about if a drug is working or not working, but it doesn't tell us the whole story, and it really doesn't correlate below a certain threshold well with the whole picture of what's going on. And these are just discussion points. There's really no wrong or right answer here, but what symptom do you think bothers your patients with ITP the most? Bleeding events, fatigue, cognitive impairment, or other? So bleeding events and fatigue coming in with the most votes, and actually fatigue at 64%. So we're going to talk a lot about fatigue. Really interesting that a lot of you in the room are already identifying that with regards to symptoms. So we'll go back now. So when we think about, the patient experience, there's significant morbidity that's associated with this. Patients have concerns over the risk of bleeding, and this concern can cause them to limit their daily activities and alter their lifestyles. I see this quite a bit in my practice with the adolescents that want to do competitive sports. We'll touch on fatigue and cognitive impairment that can really decrease participation in both school and work and other activities. As we heard from our patient from the very beginning, there's this unpredictability, this fear of bleeding. There can also be this social stigmatization. That's what I was talking about earlier with the skin manifestations that can be quite alarming to patients and reduce their self-esteem. And then we will spend some time talking about heavy menstrual bleeding, particularly in the adolescent AYA female patients. So heavy menstrual bleeding is one of the most severe symptoms of ITP in our female patient population. Our treatment options can really be limited due to the impact on fertility. We know that many of the drugs we have available for treatment with ITP are not indicated in a pregnant female. And our therapeutic options are also limited if we want to preserve fertility, and we can use intermittent hormonal therapy or antifibrinolytics. And we talked a little bit, there was an introduction to this with the patient, where we start to get this notion too of iron deficiency and how does that tie in, anemia and iron deficiency and the fatigue of having ITP. Data from a cross-sectional study done in the Netherlands showed that about 80% of patients now or in the past have experienced clinical menstrual problems, and about another 80% their menstruation had affected their daily life. And again, there wasn't really a clear link between this and the platelet count, likely because once we get below a certain threshold, there's not any direct correlation anymore. Also, out of a patient survey, the I Wish survey, a high proportion of women experienced heavy menstrual bleeding, and of those, they rated it as their most severe symptom. 80% of the time, most severe symptom at diagnosis. 60% reported it at survey completion as one of their most severe symptoms. So this is something we really have to pay attention to when we're doing intake with our patients in the clinic. We have to recognize the links between the symptom of fatigue to perhaps underlying iron deficiency or something that we need to go look at further. Fatigue is probably not just as straightforward as being related to iron deficiency. And I think we really haven't teased out the etiology of fatigue in ITP, but it certainly is there. In the ITP natural history study, which was a registry, this was done in about 300 patients that were reflecting back on their fatigue levels over the previous week. And you can see here, 90% reported fatigue, and another 80% said that they were bothered by their fatigue. And this was just in the last week. In the same I Wish study, they asked both patients about their fatigue and then physicians about how they perceived fatigue in their patients. And here, 50% of patients reported fatigue. About 40% of physicians reported that they perceived fatigue as a problem in their patients. And then another 40% of patients reported that increasing their energy levels was a top treatment goal. So again, one of the things we have to do is learn how to translate this into treatment goals when we're talking with patients. We also have similar data from children. So this was an observational study of children that was receiving second-line therapies for ITP. It was a mix of younger children as well as adolescents. And they reported similarly high levels of moderate to severe fatigue, about 50% in both children and adolescents. And just to give you some idea, this was using a Hockenberry score, and these were similar to rates of fatigue reported in children with cancer. The impact on a patient's psychological and emotional well-being has also been demonstrated through patient survey data and the patient registry data. So when we look at the PDSA patient registry, again, 300 patients looking at anxiety over the last 7 days, we can see here that about 50% needed help with their anxiety or found it hard to focus on things that they needed to do because of their anxiety. And again, in the IWISH study, about 50% of patients felt that ITP was negatively impacting their psychological or emotional well-being, with particular focus on that the condition would either worsen, the unexplained fluctuation, the importance of a stable and safe platelet count, and feeling anxious and nervous. And this is exactly the voice that we heard from our patient at the beginning, this roller coaster. And that really is when we get into following these platelet counts and the ups and the downs, that seems to be where a lot of this anxiety can lie. So cognitive impairment is an area that we're starting to understand better through some recent studies that have come out. The first was in patients with ITP. There were 69 patients were assessed using a cognitive test and as well as MRI scans. And in that study, 50% had at least one impaired cognition domain, with episodic memory being the most affected. And in another study, this was a sub-study that was done as part of the LUNA-2 trial. There were 49 patients that were assessed using a cognitive assessment. And of those, 60% of patients had clinically important cognitive impairment. It was mostly in attention. And this severity was actually comparable to those with mild traumatic brain injury. And this is an area where I think we really can do a lot more work to really understand this and then understand the impact of this cognitive impairment on quality of life and on fatigue and the toll that it's taking on patients. Fatigue, iron deficiency, cognitive impairment, all of these things lead to not being able to get through the day the way a patient would like. And their ability to undertake these daily tasks is greatly impacted. And again, this is some data from the IWISH study showing that there's experience with difficulty in concentration. There's a lot of time missed from school and work to attend doctor's visits, to be in the hospital. They may experience limiting their travel, a fear of being away from their home medical center. Many patients report that they've actually considered either reducing or not working anymore. Productivity at work is negatively impacted. And then our regular activities outside of work are actually also impacted, whether that's from feeling exhausted and fatigued or some other reason for wanting to avoid a particular activity. How often do you discuss health-related quality of life with patients in your practice? Every appointment, every 6 months, if the patient mentions a decrease in their quality of life, or other. Wow, well, some of you get a gold star. It's the 40% that check in at every appointment. And then about a half of you said, if the patient brings up something that raises the flag, then maybe we'll delve a little deeper. So let's go to our next question, which is of those of you that are assessing these factors, do you use patient-related outcomes, something formal in your practice to do this assessment? Yes, no, sometimes, or other. I think this is actually pretty reasonable. And I'll tell you why in the next slide as we go through this. So we have numerous patient-related outcome measures that we can apply to assess the impact of ITP on a patient's quality of life. And you can see here that some of these are very general tools. Some assess general health status, very specifically fatigue or energy. We have measures that can start to get at worry or concern. And then we have true psychological somatic symptom surveys. And these are generic. They're not designed to be specific to any component of ITP. I think they're helpful in the sense that they can let us compare patients living with ITP to normative populations and/or patients with other chronic conditions. But they don't allow us to get very granular in terms of ITP itself. And so that's where there's been developed more of these ITP-specific tools the ITP Life Quality Index, ITP Patient Assessment Questionnaire, and then specific to pediatrics, the Kids ITP tool. These can allow us to really get a little bit more at the granular level of what's going on specific to ITP. And I think they're very helpful, particularly if we're doing a study where we want to see if ITP quality of life changes with a particular intervention. It's much better to maybe use something that's going to really address the specific symptoms. I'm not surprised that most of you are not applying these in your clinical practice. They're really not designed for that. Many of them are sheets long. That the SF36 is called that because it's 36 questions, and these are a lot of forms for patients to fill out. And so I think one of our jobs is to find ways to make these tools applicable as screening tools in the clinical setting. We have several efficacious treatments for ITP, and as you'll hear from later, the list is going to get even longer. And we have various factors that we really need to think about when we're treating our patients. We have our initial or emergent therapies, of which corticosteroids continues to remain the backbone. But as all of you are aware, there's significant toxicities associated with prolonged exposure to corticosteroids. And so we need to start moving on quickly to our second line therapies, which include the TPORAs, anti-CD20 therapy, SYK inhibitors, and then our historical of splenectomy. But each of these varies in their treatment-related side effects. Patients may require remaining on treatment long-term, which may not be desirable for their lifestyle. There are limited options for patients who are refractory or intolerant to these therapies. And really, the selection should be considered in the context of a patient's preference, values, and beliefs. And this is where we start to introduce the concept of shared decision-making, which really results in a treatment decision that's individualized to the patient and the phase of the disease, and taking into account all these treatment goals and all of the symptoms that we're having as a whole that we just talked about. So I'm going to pause here. We do have time for a few questions if anybody would like to ask anything specific to the content of that before moving on to some really wonderful cases that will exemplify and bring out a lot of what we just talked about.
How do you counsel a patient to help manage your symptoms of fatigue, anxiety, or cognitive impairment? What do you tell a patient who says, I've got these things?
So I think our first job is really to acknowledge it and validate it. And then I think our second job is to make sure that there's no other medical cause behind it. I think we never want to say this is just your ITP and be overlooking something else that could be going on medically. And then I think it's really, I sort of take on a multidisciplinary approach of really trying to discuss where the fatigue might be coming from. Sometimes it's lifestyle changes that can be made. Sometimes it's connecting them with a support system that can help them, and then really encourage them as much as possible. And we know from some work done in other conditions where fatigue is common that sometimes it's really encouraging. How can we find those activities that will get us re-engaged, that will help us push through that fatigue? And it's a very difficult conversation to have, but I think when you work together as a team, you can find those things.
And maybe the second and last question before we go on to the next speaker, what is the pathophysiology in ITP that causes the fatigue?
Oh, I don't think we know that. That's $1 million question. I think there's a lot of different components, right? We've talked about the anxiety, the social changes that people make, the cognitive impairment. There may be something fundamental about the disease itself in terms of inflammation, cytokines. People have proposed serotonin levels that I don't think really is the source. So I think likely it's multifactorial, and we haven't really identified any one specific factor or medication that we can give that's going to fix it.
We have room for one more, and I think it's interesting for kids. How do you manage adolescents wanting to play contact sports, but their platelets are between 20 and 70,000?
So I think it depends on the sport and the platelet count. We've done some survey data, and there is some survey data out there to sort of line up sports with thresholds. Arguably, there's a lot of variation for certain sports. I will say that there are times, for me, quality of life is an indication to think about treatment. You always have to weigh it against potential side effects, but I think it's really a matter of discussing how important that sport is. Is there some other sport they could do? What is their platelet count? Is there a therapy that they could get that might help them achieve that? But it's not, to me, it's not a one shoe fits every patient. It really is engaging in a discussion about the sport, platelet count, quality of life, and impact. Okay, I think we're going to move on. I'm really excited for this next part of today's symposium, which will be patient cases. And that's with Dr. Castellano, so I'll let her come up to the microphone now.
Well, thank you for the kind invitation. Thanks to you all to be here today. And now we go to the real practice, the day by day, and the situations you have every routine clinic. And I hope we have burning topic to try to answer here, to discuss with you all. So here we have our first patient. She is called Sarah. Sarah is 24 years old, female, and with no personal, no family history of bleeding or any problem. So finally, she is suffering from heavy menstrual bleeding. That is very common, as Professor Neunert has described before. In the last 10 days, she has a PVAC of 112, so clearly heavy menstrual bleeding. And at the same time, she has started with petechia in the body, in the points with the heart pressure. So in the normal life, she used to go to swimming, but she feels very uncomfortable because of the change in the menstrual situation. And on the other hand, she feels ashamed because of the petechia. Something we have to keep in mind is the picture of a person who has, from her point of view, and she feels ashamed about this. On the other hand, she feels very, very tired. She describes as a terrible fatigue, and even suffering from a high heartbeat, and experience headache, and even shortness of breath when she is trying to do some kind of efforts during the day. So with all this data, she came to the emergency room, and this is what we find there. She presented an hemoglobin of 9.2, a median corpuscular volume of 81 femtoliter, platelets 1,000, leukocytes 8,000. And we look to the blood smear, and we confirm this a thrombocytopenia with no dysplastic or not any other advice of other disease, hematological one. The clotting test, APTT, TP, fibrinogen were absolutely normal. And from biochemistry point of view, we have normal liver, normal renal parameters, and only a ferritin of 2 nanogram per milliliter that it could be in relation with the anemia she's presented that the heavy menstrual bleeding allows this day. No problem with HIV, with hepatitis B or C. So in this condition, she was diagnosed of ITP, because to diagnose of ITP could be very simple and very complicated. Why? Because it's an exclusion criteria diagnosis. So what we have to do in the very beginning is to do a good anamnesis, to explore the patient, and to have these minimal results about the analysis we have mentioned before. So with this data, ITP, what is my goal? What I have to try to do and to explain to this girl to feel comfortable with the situation. First of all, we have to try to have secure platelet numbers, and that is quite variable because we have been talking about this before. It's not the same a child than a people of 80 years old or a woman with 24 years old. On the other hand, to reduce the toxicity, to try to treat the patient with the minimum effective doses of the drug we selected. And the most important thing, to normalize life with a sport, going to school, or going to the work, taking care of the babies or the persons who is living with these people. So with this, and here we have the first question, what would you use as a first-line therapy in this woman? Dexamethasone, prednisone, intravenous immunoglobulin only to manage minor bleed events, or other situations? So please, half to half, nice. I don't believe we will going to have this because dexamethasone is not so frequent depending on the countries. So for example, in mine, in Spain, we are using more and more dexamethasone, but in other countries it's not that way. Well, we can discuss later, which is the option on how to choose between them. Well, with this girl, finally, we prescribed 1 cycle of dexamethasone, but the platelets were not stable, so she received finally 4 cycles. Her platelets returned to normal situation, and she goes on with her life. But what happens normally? Between 5 and 6 months later, we have a relapse. In this case, we have a relapse 5 months after the end of the treatment. And she started again with the same situation, the fatigue, the few petechia, but now she knows what's happening. So she went earlier to the doctor. In this case, we don't have anemia. Platelets were 8,000, leukocytes again normal. We confirm again, it's quite important to reconfirm that we are in front of an ITP because things can have an evolution. We can have no other autoimmune disease related and few months after we can find it, or any other disease who can produce a decrease in the number of platelets. So again, coagulation test normal, biochemistry normal again, and no immunology problem with regard of infections, viral infections, and the anti-neutral antibodies, proteinogram, and immunoglobulins were absolutely normal. So again, we can be sure that she is very young, have no immunodeficiency, etc. So in this case, we are again in front of a relapse, which should be or could be the option you choose to treat this girl. 3 cycles of dexamethasone again, prednisone, 1 milligram per kilogram per day, 1 cycle of dexamethasone or intravenous immunoglobulin, and later started with the thrombopoietin analogs, or directly thrombopoietin analogs without rescue treatment. Wow. Okay, we do it like that. No, but you have many options, because on one hand, you can say, well, it's only 5 months, we can try with the dexamethasone again, to try 3 cycles to see what's happening, or with prednisone. But probably if you have a so close relapse, it's better to rescue her and to start with the thrombopoietin analogs. Or even if she's not bleeding, directly go to thrombopoietin analogs. We can discuss later. So we gave her 1 cycle of dexamethasone to try to rescue. And 1 week later, platelets were 46,000. So we started directly with the second-line treatment. In this case, it was AV Thrombopac using 20 milligrams a day. So her platelets has been between the range you have there, between 80 and 105 during the 4 months of treatment that she's now keeping since the moment of the diagnosis. So good evolution. But, as always, adolescents are complicated, but women between 20 and 30 are complicated too. Why? Because we are in a very special moment of our life, and normally in this moment we try to be mothers and to get pregnant, and we have to give advices about this. So in this case, in the last appointment, Sarah tells us that she has been talking with her husband, and she's considering to get pregnant and to have a baby. So this is a situation where you have many doubts. For example, which is the treatment I will need? I'm going to relapse. Is something going to change? What is happening with the baby? Many things at the same time in your head, and it's good to have a plan to how to proceed along this situation. So how would you best support this patient in her conception and pregnancy journey? So first, discuss the risk and benefits of remaining of AV Thrombopac during conception and pregnancy. Second, suggest to switch to prednisone with dose tapered, getting to the minimum effective dose along the pregnancy. Third, say yes to switch to intravenous immunoglobulins and start at doses. Say yes to stop treatment for ITP during the conception and pregnancy with the management relating with observation and only to be more invasive if platelets go down. And the fifth one, other. So please, so in the middle, depending on one situation. So one to discuss, of course, is the most important thing to discuss, to inform, to give all the possibilities. And in this case, the normal treatment we are providing is prednisone at low doses or immunoglobulin, but in those women who is not easy to manage, it's starting to be used, even describing in the recommendations the use of thrombocytopenia analogs. We discuss later. Okay, and here we go with the second case. This is Michael. Michael is 72 years old, male. He started suffering from fatigue, frequent bleeds in the nose and purpura. Michael is a very active man. I don't know in your country, in mine, grandfathers and grandmothers are responsible of children when the fathers go to, the mothers go to work. So Michael is helping with the grandchildren. He collects her in school twice a week, three times a week. And recently, he has been feeling too tired to care from them and started with bruising. He is 88 kilos of weight, is suffering from atrial fibrillation, hypertension, and diabetes type 2. And the current treatment are apixaban for the atrial fibrillation, benazepril, and metformin for the glucose control. So a normal 72 years old man. He came to see the doctor, and what we found is an hemoglobin of 12.3, platelets 22,000, and all the rest more or less normal, as we have commented before with our other patients. So at this point, how would you manage Michael anticoagulant therapy? This is something we are going to see more and more, because 20% of people older than 60 years old are going to suffer from atrial fibrillation. They will need probably antiplatelet or anticoagulant in the majority of cases, anticoagulant secondary prophylaxis treatment. So in this case, option 1, maintain anticoagulation with apixaban at full dose because his platelets are higher than 20,000. Stop anticoagulant therapy because his platelets are lower than 30,000. Maintain anticoagulation with apixaban at half doses because platelets are between 20 and 50,000. Or finally, discuss the risk and benefits of staying on anticoagulation therapy with Michael. So please stop anticoagulant therapy because his platelets are lower than 20. Okay, here we can discuss a lot of things because I think in the guidelines or the suggestions, they recommend to stop anticoagulant treatment when you are lower than 50,000 platelets. But on the other hand, and to reduce the anticoagulation dose to the half of intensity if they are between 20 and 50. But I want to introduce maybe two ideas. One, not all the patients bleed the same. You can find patients suffering from ITP that they have no bleed, even with 15,000 platelets, and other patients that with 25,000 platelets starting bleeding. So this is something to keep in mind. And another important thing is the thromboembolic event risk is not the same in all the patients. I mean, it's not the same to suffer from a venous thrombosis event in the last 3 months that 2 years apart from now. And it's not the same to have a stent in your body in the last 12 months that to be 3 years with it. So the thromboembolic risk and the situation is absolutely different, and we have to decide and to comment with the patient what is the best option. So what we did with Michael? Well, in this case, we stopped it because he was not use not common. It's a new diagnosis of ITP. We are not aware about how he was going to behave himself. So we started with prednisone, 1 milligram per kilogram, little less. And platelets of Michael increased, and they were between 30 and 50,000. So another question for Michael. How long do you recommend it? Michael continues with prednisone treatment before considering a second-line option. First, up to 4 weeks. Second, between 6 and 8 weeks. Third, up to 16 weeks. And the fourth, other. You say the truth? Yes, this is what we should do. Not to be more than 6-8 weeks with the prednisone. But I invite you to revise what we do in our clinical practice to see that in the majority of cases we use more time. So here we go. After 3 weeks of treatment with prednisone, platelets were stabilized, but this was not easy to manage Michael because of the problem with the glycemia. So we decided to start tapering prednisone to see what's happening, but the number of platelets dropped down. So we have to decide another option, in this case, a second-line treatment. So here we have the 4 possibilities. So first one, TPO. Second one, SYK inhibitor, in this case, fostamatinib. Third one, rituximab. For one, others. Okay, so this is something we are starting to discuss because we don't have a head-to-head study to compare TPO with FOSTA with any other. But it's true that all the patients included in the studies, TPO or FOSTA, are not able to have any thromboembolic event in the 12 months before. But in FOSTA, it's 0.7% of events, and with TPO, it's a little higher. So here we go again. Michael started with fostamatinib at doses of 100 milligrams twice a day. And during the first 12 weeks, he started with the treatment. His platelets are between 80 and 100, and everything goes properly with no adverse events related with the drug. He's improved the energy, bruises disappear. He started again with the anticoagulation treatment and with the normal life. I mean, the normalization for him was to go again with the grandchildren or with the normal life. So finally, in this case, as we see that the platelets are quite stable, we have another question to introduce in this patient. We have mentioned at the very beginning that it's good to find the minimum effective dose to prevent toxicity. So in this case, and here's the question, what do you do next for patients demonstrating clinical response? Discontinue fostamatinib because he has been with platelets higher than 50,000 during 12 weeks. Second option, discontinue fostamatinib if platelets are higher than 100 and maintain for at least 6 months without rescue treatment. Continuing long-term treatment unless the patient stops responding or experiences significant toxicity, and for others. Well, here ends to long-term treatment unless the patient stops responding. Okay, but it's something that we consider with the TPO and probably with fostamatinib, the drugs coming later. It is good to try to give the drug you need, no more, no less. So to try to do some kind of tapering if platelets are stable, higher than 100, with no peaks, it's a good idea in these patients. So thanks a lot. Questions?
We do have one question that came in, and this is regarding our patient that you presented that had the heavy menstrual bleeding, and we brought this topic up. Do you have a preference for an OCP to use with heavy menstrual bleeding? Combined OCP better at controlling bleeding, but perhaps higher thrombotic risk compared to a progesterone only?
Okay. Well, to tell you the truth, the hematologists at the very beginning, we are afraid about the tranexamic acid and to measure it with the TPO. But if you go to the publications and all the data we have in the literature, if you use tranexamic acid and the normal doses and recommended doses during the 3-4 days that you need for the heavy menstrual bleeding, you are supposed to have no problem with this. Of course, you have to comment with the person who's suffering from this, but in my common practice, I'm using the tranexamic acid very frequently.
Wonderful, thank you. So next, we're going to have Professor David Kuter coming to talk about emerging therapies for ITP.
Thank you, Professor Neunert. I presume everybody can hear me okay in the back? I'm going to talk about things that might change in the future in terms of therapies for ITP. I'll use the next 2 hours to talk about this topic. That was said to see if you're awake, okay? So I'm going to mention to you that, as you know, that ITP is the problem of impaired platelet production, but also a problem of increased platelet destruction. I'm not going to talk at all about new therapies that increase platelet production. That pretty much is resigned to the TPO receptor agonists and the several new agents such as heterothrombopeg that are being developed globally. So I'm going to focus on novel therapies that affect the destruction of platelets, and I'll take you through this in sort of a cartoon fashion. This is my view of ITP. This is a macrophage right here. This is the Fc gamma R3 receptor, and here are some platelets. If I all of a sudden develop ITP, I have antibodies that come along that are going to attack my platelets and cause me to destroy my platelet numbers. So the first question asked, and this is a sort of a Gedanken experiment, what would we think about doing? The first approach to treating ITP is, can we make the antibodies that are there disappear? And the answer is yes and no. We have some therapies that we currently have. Splenectomy may decrease your antiplatelet antibody. Corticosteroids might. Anti-CD20 agents such as rituximab might do that. And the neonatal Fc inhibitor, and the one we currently use is IVIG, a mechanism which we don't have time to talk about, but IVIG, as one of its many mechanisms, can alter the clearance of IgG when given in large amounts. But there's a whole bunch of new agents here, which I'll try to talk briefly about a couple of them. We have anti-CD38 molecules. I'll talk about one called mezagitamab. The second I'll talk about is a neonatal Fc inhibitor, efgartigimod. I'll then simply mention to you there are a number of anti-CD40 molecules which are not currently being developed aggressively. I'll mention to you a brand new idea called IgG proteases that may come into discussion in the near future. I will mention to you the BAFF receptor inhibitors, ianalumab, and I'll also just comment upon the fact that bortezomib, and there's an abstract on this, I believe, on Monday, and other immunomodulatory drugs are being studied in ITP. So I'm going to focus on 4 of these different things in the next few minutes. So CD38 is a really nifty molecule. It's been around for maybe 40 million years on sea urchins and other single-cell organisms. It is a nifty enzyme shown right here. It is an NADase, and it alters calcium flux in a lot of different cells. The immune system, as it evolved, has used this for many different things. It's been appropriated by our immune system to activate B and T cells, and it's a very nice target present on many cells. And as you know, if this is a myeloma cell, as we've labeled this here, giving an antibody against CD38 will bind to the CD38 receptor, causing cross-linking and programmed cell death of the myeloma cell. But there are a lot of other mechanisms by which macrophages will target these molecules on the surface of lymphocytes and plasma cells. So this is an interesting way to make the plasma cells making antibody and other immune cells be decreased in activity. And there's a molecule that we presented at ISTH called mezagitamab. Don't you love the names of these molecules? This is also called TAC-079. This is a monoclonal antibody that attacks CD38. And I'm simply going to ask you to focus on the orange bar here. These are ITP patients given the larger dose of the molecule. These are weekly injections for 8 weeks. The control patients are down here, and they've had no response. What's interesting is there's a rapid rise in platelet count in these patients, and it persists for a long period of time. And so what's nice about this molecule that's undergoing phase 3 studies soon is this molecule very efficiently and rapidly raises the platelet count, and the responses are well maintained. Now, this is a typical ITP blurb about different response rates. There are many ways to quantify responses to therapy in ITP. I will simply comment upon you that a complete response is a platelet count over 100,000 on 2 consecutive visits. That occurred in 82% of patients given this drug in the highest dose. If you say, well, what do you need to prevent bleeding? Well, a platelet count over 30,000 and usually 20,000 above baseline may be hemostatic, and in this case, 100% of patients at the higher dose had this occur. These are ongoing early data for this form of therapy. Many of you know that the neonatal Fc receptor is a very interesting receptor. We imbibe from our circulation about half our plasma volume every day. It gets penocytosed, pH drops, and there's a lovely receptor called the neonatal Fc receptor shown here that avidly binds IgG and prevents it from being catabolized. Other proteins are destroyed, the pH then rises back to physiologic pH, and IgG is released into circulation, giving it a half-life of some 28 days. But if you poison the neonatal Fc receptor, shown here with an anti-FcRn antibody, shown in green, the receptor is blocked. You imbibe both pathologic and normal IgG, and the IgG is catabolized along with the other proteins. And when you recycle to the surface, you don't have any antibodies left. And this is a pharmacologic plasmapheresis for reducing IgG levels. A structure which many of you know called efgartigimod is approved in several countries for treating myasthenia gravis. It is a very nicely modified IgG that has a very sticky Fc portion here that makes it stick to the neonatal Fc receptor and not come off readily at physiologic pH. When this was studied, and this is work that was published by Catherine Broom down here last year in Lancet, the patients who got placebo had no change in their total IgG level. Those that got the efgartigimod had a nice decline in their IgG level by about 60%. And the question was, in these ITP patients, what happened to the platelet count? And shown here is the placebo patients who had no change. All the patients who got efgartigimod had a modest rise in platelet count that persisted. And if you look at these endpoints, and the common endpoint in ITP studies is considered a durable response, which is a platelet count on more than a couple of the last visits. 22% of patients responded versus 5% of those who got placebo. Now, the problem with the study, this was an IV formulation. When a sub-Q version was used, the results did not show benefit in platelet count change. Why this difference occurs is not yet explained. Another target for treating or making antibodies disappear is to remember that the B-cell activating factor binds to the BAFF receptor on lymphocytes, for example, and stimulates them and lets them grow. If you use an antibody, such as VAY736, and this is a presentation you can hear on Monday at one of the oral presentations, this binds the receptor, it inhibits the receptor, but also like rituximab, it causes clearance of the B cells once bound by the antibody. And there are a number of studies underway with this molecule now. You can hear one of them, and this is abstract 710 on Monday. The last molecule mentioned here, which I think is really cool but not yet ready for prime time, comes from bacteria. This is a protease that is made by strep pyogenes. It is what makes bacterial infections kill us because we don't respond very well and we can't destroy the bacteria by antibodies. What this enzyme does is it cleaves IgG into an FAB, an FC portion, and neutralizes the antibody. A commercial form of this molecule that was investigated some 8 years ago, called imlifidase, made the antibody levels in patients with HLA incompatible transplant needs, made the antibody drop to 0 for 3 to 5 days. The pathologic antibody virtually disappeared, and these patients were able to undergo transplantation of kidney. Now, one problem with this molecule, you give it once, it's a one-time deal. You give it a second time, it's highly immunogenic, and it doesn't work a second time. And this has led to an interesting group of experiments done by several different companies trying to make an invisible IgG cleaving enzyme by modifying residues that are antigenic or blocking the sugar residues. And abstract 2562 is presented, I think, also on Monday, looking at this new molecule, and there are several in development. And I'm eager to see how these molecules work in immune disorders. So once we had our platelets bound to antibody, what happens commonly next is complement gets activated, but I don't have time to talk to you about the complement drugs, which have not yet quite seen prime time in terms of therapy for ITP. But what happens is the antigen-antibody complex, as many others do, binds to the Fc gamma R3 receptor here, activates the Syk kinase and Bruton kinase pathways, and the platelets are destroyed, and this is what causes the thrombocytopenia. So the question is, can we inhibit this macrophage pathway by different medications? And we already do that. Corticosteroids do that to some degree. The vinca alkaloids have been known to do that for quite some time. Splenectomy takes away the major site of macrophages. IVIG can block the macrophages to some extent. And as we've talked about already, fostamatinib, which is a Syk kinase inhibitor, can also inhibit this pathway. I'm going to bring to your attention 4 areas of research. I'll talk about 2 of them. The 2 areas I won't talk about is the fact that we're learning more about how IVIG works. We've come to realize that it's a sialylated form of IVIG that's the most effective in ITP. We also know that recombinant FC portions or multimers are also active in inhibiting the macrophage. Studies right now are not robust, but these are interesting molecules. I will spend the remaining of my time talking about the Bruton kinase inhibitors, of which rilzabrutinib is one, and the other is the Syk kinase inhibitor, a new one called sovleplenib. Again, these are very robust names. So let's go back to the targets. We're going to target Bruton kinase with rilzabrutinib. We're going to target Syk kinase down here with sovleplenib, and we'll see what happens. So let's go to sovleplenib. This is an interesting molecule. This is called a kinomap. It shows that fostamatinib inhibits right here this part of Syk kinase, but it has a whole bunch of off-target effects, which may account for its off-target effects and side effects when given to patients. We've talked about hypertension and diarrhea already. Sovleplenib is more specific and a bit more potent than fostamatinib. It inhibits Syk, and it has very few off-target effects as shown here. In a nice phase 3 study done by our colleagues in China, they gave patients sovleplenib, these are ITP patients, versus placebo, and they show that a durable response, again, this is a response where 4 to 6 of the last visits in the second half of the study had platelet counts over 50,000. Enrolled patients had platelet counts less than 30,000. The response rate here was 48% versus 0%. If you look at other qualifying platelet responses shown here, and this is how we cut and dice data for many ITP studies. If you look at 2 consecutive platelet counts over 30,000 and double from baseline, this happened in 73% of patients given sovleplenib versus 6% of patients given placebo. So there's a potent platelet response with this drug. Now here are the platelet counts. These are the placebo patients. These are all the patients getting sovleplenib, both the responders and the non-responders. Additional secondary endpoints are important in all these studies. If you look at the need for rescue therapy, such as IVIG or platelet transfusions, it dropped considerably in the patients given sovleplenib. If you look at the ability to discontinue other concurrent ITP therapies, such as corticosteroids, this happened more frequently in the arm given sovleplenib than the placebo arm, but the p-value is still not significant. And the WHO bleeding scores improved on this drug. So this is an interesting future drug, possibly in North America, to study, and it will give us an interesting idea as to whether we have a better molecule than fostamatinib. The last molecule I'll talk about is rilzabrutinib. This will be presented at as abstract 5 at our plenary session on Sunday. Rilzabrutinib is an oral reversible BTK inhibitor. It does not affect platelet aggregation, such as our favorite molecule for the oncologists here, which is ibrutinib. It binds to the Bruton kinase shown here. It does it in a covalent fashion, but because this is a disulfide bond, this is a reversal bind. It has a short dwell time in the circulation, but it gives prolonged inhibition of BTK. Unlike ibrutinib, which causes reduction in aggregation in response to collagen, rilzabrutinib has no effect upon platelet aggregation and aggregometry experiments. We have looked at this molecule in great extent. It has many different modes of action since BTK is necessary for a wide variety of different physiologic and pathologic events. Inhibiting BTK will, as we do with ibrutinib, will prevent antiplatelet antibody production and decrease lymphocyte activity. It will, as I said before, inhibit the phagocytosis in macrophages. And what I didn't talk about is it also affects the inflammasome and can reduce inflammatory signals in a number of different settings. In a study we published a couple of years ago, we gave patients 400 milligrams twice a day. This is not a placebo-controlled study. Of the patients we treated, 18 patients, or 40%, had a rather rapid rise in platelet count that persisted for 24 weeks and continued for many more days on study. The non-responders are shown down here. What was interesting about this, if you look at patients who have platelet counts over 50,000, they occurred for a median of 72 weeks on study with this medication. Side effect profile was rather modest. It was diarrhea, nausea, and fatigue. What I want to draw your attention to is a pooled analysis of two studies, the one I just showed you, and additional patients with the same study design, and this data will be published very shortly. This was presented in part by Dr. Kuter and others at ISTH previously. And what I want to do is show you the study data from the pooled study. Again, 41% of patients had a response, a platelet count over 50,000 on 2 consecutive occasions. And then we went back and analyzed that and asked, well, what about having a platelet count present on 8 of the last 12 platelet counts? This occurred in 28% of patients. And you say, well, gee, that doesn't sound very robust to me. What's going on here? Well, what's going on here is that most of the patients in the study were patients who were highly pretreated. Many had disease for 6 to 8 years. Many had failed many other therapies. And if you look at the use of rilzabrutinib as a third-line therapy, again, 37% of patients had 2 platelet counts rise over 50,000. And again, 26% had a more durable response. But if you look at patients where this drug was given second line, the response rate, again, 2 consecutive platelet counts was 86%, and a more durable response was 57%, which is comparable to that seen with TPRAs. Again, be very careful here. This is a small number of patients, and further analysis needs to be done. You'll hear more data about this at the plenary session in terms of the phase 3 study, which has recently been concluded in this. So let me stop and say that ITP is an interesting area right now for novel molecules to be developed. I focused on molecules that inhibit the destruction of platelets in many different ways. It is a disorder of reduced platelet production, which I didn't talk about, and heterothrombopac, as I said, is a new TPRA that is widely used by our colleagues in China. It may enter use in other countries. And as I said, ITP is, again, conceived as a platelet destruction disorder. You can try to reduce antiplatelet antibody by FcRn inhibition, by IgG proteases, just make them disappear, by inhibiting BAFF receptor, by using anti-CD30 molecules. And Dr. Ganima, who may be in the audience, has a study that is being done with daratumumab. I talked to you about mezagitamab, the drug I just presented. I didn't talk about complement inhibition with sutimlimab and iptacopan, both of which have efficacy in ITP to some extent, but these are not being pursued actively to my knowledge. And then there's a whole group of molecules that try to inhibit phagocytosis at the macrophage level and stop the chewing of platelets. They include modified IgG, which I think we'll hear more about in the coming years, which is hypersialylated IVIG, and also recombinant Fc multimers. I'm very excited about the Syk kinase inhibitor, the sovleplenib, which may mitigate some of the side effects we have with fostamatinib, and it may be a more potent drug. I can't say for sure. That requires more study. And finally, as we'll talk about on Sunday in more detail, the BTA inhibition with rilzabrutinib is quite an interesting molecule with minimal or no side effects in terms of its use. This is just a short list of what's in the pipeline. The pipeline's bigger, ranging from CAR T cells, which I can't say I'm too enthusiastic about it, to bifunctional antibodies against B-cell antigen CD3. This is a very exciting time to be working in ITP, and you'll see there are many new therapies in the pipeline that you'll hear and read about, several of which are being presented in this meeting. And just to give you a summary of things which I thought was interesting, the BAFF inhibitor data will be presented on Monday. The rilzabrutinib phase 3 study will be presented at the plenary session. There's yet another Syk kinase inhibitor presented here. And you can look at this list. There are a lot of things in the pipeline which bring us into the new era of treating ITP. When or if all these molecules will see the light of day from an approval point of view will depend upon the data. Thank you.
Questions? So we have 2 questions that have come in for Professor Kuter. The first is, do you expect any of these new treatment options to be appropriate for first-line use or perhaps newly diagnosed, or should we wait until current treatment options have been exhausted?
Yeah, I think many of these molecules are very interesting molecules. They may work fast, and they may work fast enough that you can use them up front. So the data I showed you for rilzabrutinib, for example, not to just hark on that, the response rates, most patients responded within 2 weeks to therapy. So if someone has a platelet count of 13,000 and is not bleeding, you could consider starting that or other agents, and that may also be true for sovleplenib. So I think that there may be a room for these agents either up front in the first weeks of ITP or even possibly to replace the need for corticosteroids. This all depends upon the need for studies to prove these points, though.
And then sort of linking back to our initial discussion, has fatigue or other patient-related outcomes, are they being assessed during some of these new studies?
Yeah, all these studies have a component of PROs and also assessment of fatigue. I will encourage you to attend our session on Sunday to discuss whether fatigue is affected by rilzabrutinib. In general, patients who respond to TPRAs have an improvement in their fatigue, and that was true back when we used Nplate years ago, that responders had fatigue better. But I think right now, this is becoming increasingly a focus of major outcomes in ITP. It's not just the platelet count stupid. That's what I'd probably say.
And then we have one last question just about the inclusion of children and age groups of these drugs. And I didn't ask it.
Yeah. So you want to answer that one, Cindy? Okay. I think right now that all these drugs have applicability in children, but studying children is not my shtick, but Dr. Neunert can comment upon that.
Yeah, no, I think that, our hope is that all of these reach the pediatric population, but obviously safety concerns and safety signals have to be taken into account. I think in our minds, once they're, maybe it's more of a weight that's appropriate versus an age. So,
yeah, it took us many years to get the TPRAs to kids, as you know. So,
indeed. Okay, we're going to move on now to sort of the last part of our symposium, which is our panel discussion. And so I'd like to circle back. We have this landscape of therapy, and we have many new drugs coming out that may even make the landscape look a little more overwhelming in a very positive way. And so I think this is where we want to come back to this notion of shared decision-making. And every patient, every individual that comes to us really is going through their own journey. And we need to put that together in our treatment decision-making. And what we want to do is take our experience, perhaps it's our own knowledge, our own work that we've done, guidelines that we rely on. We want to combine that with the patient context, their experiences, the context of their goals, what goals they're trying to achieve, all those things that we talked about at the beginning, the specific symptoms that we need to address. Make sure that our patients understand risks and benefits, the consequences of different treatments, and the characteristics of their disease that maybe make them unique or different from other patients. And then we need to empower them. And we're trying to empower our patients to help be part of the decision-making process. And really, we want to meld together evidence with experience and with patient preference. And that's how we arrive at shared decision-making. And that's really of value in terms of increasing patient satisfaction, adherence, and really making it a partnership that's just going to help them throughout this journey. So we do have some questions that have come in, and I guess the first really gets at, could advocacy groups be leveraged to teach patients to fill out the ITP pros and bring them to their appointments? And I think this is a great place where we can start that process of empowering patients. And I think that there's a lot that we can do before the visit to make the visit as productive as possible. I think we need to refine our pro measures. I think if we were to give a patient an FF36 to do at home, it would not be that productive. But perhaps there are several key targeted questions that patients could do, or maybe while they're waiting to see the physician, to really enhance that discussion and take that number up even higher in terms of the number of you that are asking at every single visit questions related to quality of life and fatigue.
Yeah, I work in a cancer center, so all the cancer patients have these forms they fill out before the doctor sees them. We don't do it for ITP, and I think it behooves us as a community to actually think of a short form we could use to get the information we want to have that we could give to patients.
Yeah, but the problem is there is not only the time and to try to collaborate with the patients.
for me, the most difficult thing is that you have after they complain, they do the registry. After that, you have to translate it into numbers and compare these numbers with the visit before. And that is for me the most difficult thing, because a patient is sitting there when they are waiting for you to be seen. 20 minutes, 25 minutes, you can try to. The problem maybe in our routine is to translate it and compare. And that is what I really don't think no one does. It's something we have to improve in that way, I think.
The next question is, what is your experience of shared decision-making to support personal treatment plans? One of you want to start with?
Well, again, I think any don't take this wrong. I think any good doctor, from a primary care doctor who's specialist, needs to talk to patients and ask what's going on and get to know the patients better. I think in our very harried current medical environment, we're actually, if you're a primary care doc, you get 7 minutes, then the patient's out. So there's not any time to do this here. We have the luxury as a specialist, I think, for many of us to have more time to talk to patients. But the shared decision-making changes from the early diagnosed ITP to later on. So a brand new patient in emergency room very much depends upon you to call the shots unless they are diabetic and don't want to take steroids. Whereas as the time goes on, it shifts to the patient, I won't say running a show, but being highly involved.
I think too, sometimes it's good to set check-in points. We put patients on a medication and it's easy to let them sit on that and think everything's fine. And I think sometimes, to say, okay, in 3 months, we're going to do an hour-long appointment. We're going to do a longer appointment, right? Sometimes I actually ask my scheduler to book 2 follow-ups for the same patient back to back, or some way to really make sure that every so often we're really doing a thorough check-in. It's kind of, you go for your intermittent visits, and then you have your annual physical exam where you anticipate that it's going to take longer and be more comprehensive. And I think we can use that same model for how we care for patients with ITP, and really setting in some checkpoint visits where they come prepared with this knowledge that we've empowered them with, perhaps they're using and engaging with shared decision-making tools that have been created for them. And those visits become those check-in points to make sure that we're really looking at the whole picture of their current treatment plan and if it needs to change.
And for me, another important point is maybe it's not the same the first visit that the visit after, because at the very beginning, I think they need answers. Yeah. I mean, which is the level I'm comfortable with, which is the adverse events. Do I really need treatment or not? Because normally everyone wants treatment to be cured for something. And this is not the situation in ITP. So maybe even the scale of the visits and the number, it's something we have to discuss patient by patient too.
Is there anything else, in the development of all these new therapies, are there any other markers, biomarkers, things that we can use to maybe identify quickly a patient that would benefit from a particular drug or a particular pathway?
Well, I think that we have published in the past that checking a thrombopoietin level predicts whether you're going to respond or not to a TPRA. So if the level is very high, the chance of a response is pretty low. So we use that to screen patients. That's not widely available in many places. It is available through Quest, but in other countries, it's not something that one can get routinely. That's the only biomarker I'm aware of. I think right now that it's sort of luck of the draw for most things.
And I'm not aware of any that predict or correlate well with other aspects of ITP either.
I mean, that's a major unmet medical need in ITP, is to get predictive variables in terms of what the future might bring. A third of all adults who present with ITP, if you just treat them with a TPRA, for example, for a year, a third will go into remission and not need anything. So it's hard to know who those patients are.
Are there any good tools I can use about shared decision-making in ITP? And there are. The UK ITP Support Association has a really lovely tool on their website, and I think we're working to make more of these available. We're working on pediatric versions. And again, I think that's where we need to partner with our patient groups and really make sure that patients are aware that these things are out there, and use those tools before visits and really use them to empower the patients.
I'd also add that one of the groups that sometimes gets us in trouble, but sometimes helps us, is many of us work with advanced practitioners, nurse practitioners, and PA. Some are good and some are bad. Some create more havoc than they fix because they don't have the comfort level of going to ITP. So it's very important to train your people who work with you to represent you in the right way, to not scare the patient. Oh my God, your platelet count's 18,000. Let's get you to the emergency room. If it was me, I'd just send them home with those prednisone or even just watch them. So it's important to make sure your staff knows the disease and can represent you in a good way.
Yeah, but something important too, I think, that the tools have to help you to be normalized on diet. Because if a tool is going to be used just to, like an alarm, to be sure that your battery is okay, that it's not useful. So I think we have to improve this, to use and to include in the routine of patients, but to relax and to decrease anxiety, not to increase it. We have to be careful with that.
And one more question. What do you think will significantly advance the care of patients for ITP into the future?
Oh.
Well, again, I think right now we have gone, I think, in large measure away from just treating ITP to get the counts up to improving quality of life. And hopefully at some stage we'll have therapies, some of the new ones I've talked about, that might make the disease disappear and giving you a long treatment-free remission or even possibly cure people of the ITP. So I think that our goals for the future ought to be in some small way, not with maybe too toxic a therapy, the great therapies that give people long treatment-free remissions or might indeed make the disease disappear. On the other hand, not to make light of this, we don't cure hypertension, we take pills. So, it's an interesting area to work in.
There was an earlier question about synergy. Do we think that any of these drugs will be used in combination or a TPO with a background? And how do we start to think about them maybe as not as monotherapy, but as more synergistic therapies?
I refer to it as more expensive therapies, but I'm just going to say that the major synergy people ought to be aware of is that low-dose prednisone works very well in synergy with a TPRA. So if someone's got a platelet got a 22,000 on a TPRA and you put them on 5 milligrams of prednisone, half the time that goes to 40,000 or even higher. So that's the one cheap synergy. But there are many studies showing that a combination of fostamatinib, which decreases destruction of platelets, versus TPRA, which increases production, may be synergistic. But I find that these, in many situations, are just too expensive a therapy to advocate for a reasonably benign disease.
But I don't exactly agree with that. Because, what I mean is that it is true that if you use one single drug and the minimum dose that is effective, perfect. But if you have a patient with problem, you can't control platelets, it's not normalized life. In some situation, and even in this study, fostamatinib, and another study published by a French colleague, and even we have sent data from Spain, many times when you combine, you use very lower doses than the one you use in the very beginning with the drugs you are combining with. So I think that is something to see case by case.
I think the United States healthcare payment, and this is certainly true in France, the costs are prohibitive to add two medications together. I would simply say that if that's the case, I'd switch to a third medication that, I would switch to rituximab or even take the spleen out. So I think right now we ought to recognize that costs need to be thought about carefully when we start adding more drugs to a disease which is not that life-threatening, and not to dismiss the patient complaints, but I've got patients who lived at platelet counts of 8,000 for 30 years and don't have major problems with it. Yeah. So I think you've got to be very careful about costs, and maybe different in your country.
Because utility change country by country, so that is something to review in every situation.
So this is a good question that relates sort of back to our case, and we didn't get too much time to discuss it during the case itself, but how do we decide between fostamatinib and a TPO agent for somebody who's failed first-line therapy? So in our case, we went on to fostamatinib, but in what setting might we use a TPO-RA instead? And a little bit of this, I think, also expands into sort of this decision-making process that we're talking about.
Well, here we have the problem that we don't have biological markers to decide between one or other. So in this case, we decided to start with fostamatinib because of the information we have with regard of ischemic events, incidents. Anyway, in our recommendations in the guidelines from Spain, we have included fostamatinib is in the second-line treatment as TIPO. So the first is to try to use TIPO, but in patients with high cardiovascular risk, with thromboprophylaxis, secondary thromboprophylaxis with anticoagulant and antiplatelet drugs. We somehow, if you have time, suggest to use fostamatinib, and that was why it was used. So with fosta, our experience is that you need 2 to 3 weeks to have the information, the response. But in those patients where you have the response is quite stable. So this was the rationale of the use.
And this is a question I have for Dr. Kuter, Professor Kuter. Is there any patient in which you would avoid a TPORA? You know, the signal of thrombosis. And
Again, I don't think TPORAs cause thrombosis, so I don't have that as a concern I have. I think that there are many patients who might have Evans syndrome or warm antibody hemolysis where rituximab may be a better drug than some other therapy. But I think for ITP patients, plain and simple, our usual go-to medication, second line, is going to be a TPRA, given its very, very high response rate of some 90% in patients, whereas FOSTA's got a response rate of 18%, rituximab 59%. So I think for now, I go by the numbers, and those numbers may change with time as we have newer agents.
Maybe here the question is that it's not TIPO, it's not other drug, it's the inflammation of the patient. You're in an acute situation and you have to do something.
No, I certainly think that taking in any other biologic picture of a patient is important when choosing a therapy. If you think there's something else that would be better addressed in terms of a pathway given a particular patient picture.
I think one thing that's happened during the pandemic is we went away from rituximab, which is a cheap and pretty good drug for many situations. It may not be the perfect drug by any means. It doesn't cure ITP as we once thought it did, but I think it's something we ought to put back into the pipeline because we tend to shy away from it. And now that, things are a little calmer in terms of infections globally, I think we ought to consider that back on our main repertoire.
And I think that's where, again, looking at the whole patient picture, I find for young adolescents, people with that kind of ANA positivity, that it remains a very good drug even before considering maybe a TPORA just in context. So there was another question about just selection of a TPORA, in the era of avatrombopag, is there still a place for the other two, and how do we sort of navigate between the three available agents?
That's usually done by the insurance companies for you. So I think right now that's probably not.
That's probably the case. And I think there is some degree of patient preference here. For some of our families with young kids, we go back and forth about, some families really it's the use of the needle that's very overwhelming. And in others, it's actually trying to navigate a diet that becomes the concern. And also for us, we were having a lovely discussion just even the other evening about the access to being able to do certain agents at home and access to that. So all kinds of barriers that we have to think about. And I agree, I think another check-in point with our patients has to be to ask them if they're suffering from any financial hardship secondary to the therapy that we have them on. I think we forget that not every patient has, at least in the States, the same copay or the same out-of-pocket expenses. And I think that's another important thing that we need to be asking about regularly is economic hardship. And then there was a question that came in, is splenectomy really a historical therapy? I believe I was the one who probably used that term. And I think, in my mind, splenectomy was historic in the sense that for the longest time, it really was all that we had to offer. But I don't think that means that it's ineffective in modern cohorts or has in any way been something that we should completely turn our backs on. But just being more cautious in which patients we select and how we use. But I'll let others comment as well on sort of the role for splenectomy in the era of modern therapies with all these other drugs to select from.
And depends on the country, and depends on the adherence, and depends on many things. So I think it is true that maybe in the countries we are living, it's not so usual to go to splenectomy actually, but in many other situations where you don't have access or you have a very bad adherence and so keep a solution or try, something to try.
I would think rarely I would do splenectomy. I haven't done one in 30 years, so I haven't used it as a prime form of therapy. But I can imagine some patients, and I would probably say that the only two patients at our hospital who had a splenectomy in the last 20 years are Air Force pilots who need to have their disease fixed and back in the air. And that's the only situation where we've done it. I think we would benefit if we did more splenectomy. But I hate creating a second disease, asplenia, to replace the first disease. I actually think asplenia is the worst disease in ITP for most people. Okay. We have some patients advocates in our front here who are
some patient advocates that are agreeing with that statement.
Yeah.
We're going to wrap up now. This has been a really enjoyable discussion for us as the panelists, and I hope for you all in the audience as well.